Okay, and good morning and welcome to the Davies Use Case webinar being presented by Memorial Hermann on potentially inappropriate medication in elderly. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker from Memorial Hermann, Suraj Anwar. Suraj, I'll turn the presentation over to you, and you can begin when you're ready.
Thank you, Arnold, for the wonderful introduction. Greetings, everyone. My name is Suraj Anwar. I'm the Associate CMIO for the Memorial Hermann Health System, and I'm here today to talk about our use case study from the HIMSS 2018 Davies Award, and it is on the use of potentially inappropriate medications in the elderly. So just a brief introduction to the elderly. We all know that they're important members of the community, and unfortunately a large portion of them will end up in our hospitals to receive care pertaining to their health. These numbers are a little old. They're from 2009, but over the time you can see the patterns are pretty consistent. They do form a big portion of the patient population. So with that said, I also want to bring up the adverse drug events, which are a significant problem in our healthcare environment. According to the Institute of Medicine to Earth's Human Report, approximately 770,000 people are injured or die annually from adverse drug events. And as a result of those adverse drug events, patients may spend a longer time in the hospital with increased costs. And 9.7% of ADEs may result in permanent disability. So it's a problem, and it is actually more prevalent in the elderly. And it is an important cause of morbidity and death in the elderly. And most of these kinds of adverse drug reactions are related to the dose, or as they're called as type A kinds of adverse drug reactions. And these are predictable, and because they're predictable, they're potentially avoidable. And that's what the Beers criteria or list addresses. It was originally conceived in 1991 by Mark Beers, who is a geriatrician by practice. And this list has gone through several iterations over the years, and the most recent one was released in 2015. There are several names or synonyms for Beers criteria. It's also called as the Beers list. So the Beers list and Beers criteria are used interchangeably. And the Beers list, what it does is it identifies the medications that are that have a risk that outweighs the benefit for these patients who are age greater than or equal to 65 years. And it is meant to inform the clinical decision-making process for our clinicians related to the prescribing of the medications for elderly patients. And it is meant to improve the safety and the quality of care for those patients. So as I stated, the goal is ultimately to improve the care of older patients by decreasing the exposure to these potentially inappropriate medications. It is merely meant to assist with identification of the medications for which the risks outweigh the benefits. It is not meant to be punitive, And it is not meant to override or supersede the clinical judgment or the individual patient's needs or values. This is a summary of the Beers criteria as per the 2012 guidelines. There were originally 3 different categories. The first category is where the medications possess a high risk of adverse effects, or there's limited effectiveness in the elderly patients. And there also may be alternatives to these medications. In the second category, we have these medications that should be used cautiously in patients who have certain diseases or disorders because they may exacerbate the specified health problems. And then in the third category, you want to use these medications with caution in the older patients because they're just more risks than the benefits. And we have a different number of medications in each of those categories. In the first and second category, we have 53 medications, and then in the third category, we have about 14. Now, as for the 2015 guidelines, there were 2 additional categories that were added. The fourth category, which is addressing the drug-drug interactions, and this is specific to the non-anti-infectives. And these are, the combination of these medications is highly associated with harmful outcomes in the elderly patients. And it can range anywhere from urinary incontinence to risk of hyperkalemia. And there are about 18 or more drug classes that interact with each other that should be used with caution. The fifth category is primarily based on kidney function, and it is meant to either avoid the medication or adjust the dosage. And the dosage is adjusted based on different creatinine clearance thresholds. And we have about 21 medications in the fifth category. There's a lot of evidence out there that supports the use of the Beers list. In addition to that, several articles have talked about how they've used alerts in their EMRs to address the problem of over-ordering or inappropriate ordering of these medications. And I've highlighted the less is more. So what we're looking for is a reduction in the use of these meds in our elderly patients. And so the request to have this work completed in our health system was first brought about by our Chief Clinical Officer, Dr. Michael Chabot. And he essentially called it the let's not boil the ocean Beers list proposal. And he said, let's start by creating CDS interventions, target specific set of medications, do it in a phased approach. Let's make sure that we have a good governance process and we have stakeholder buy-in. So let's create a review panel of clinicians, pharmacists, and informaticists to work on that list and how we design it. And so ultimately we designed a CDS CPOE alert that advises on the risk of using these meds in our elderly patients and ultimately provide alternatives as well as the ability to suggest pharmacist consultation. So I briefly talked about the governance, but more formally, we had the Clinical Decision Support Oversight Committee that managed all of the CDS requests for the system. And this Oversight Committee created a work group, which we call the Beers Criteria Work Group, and it was comprised of physicians, pharmacists, and medical informatics team members. And in addition to that, we had the Acute Care Medical Informatics Committee, which oversees all of the informatics operations or governs the informatics operations for our system. Some of the key decisions that we worked on were identifying the target medications. As I stated, we decided to take a phased approach and work on the alternative medications that would be provided to our clinicians. Our CDS interventions consisted of alerts, order sets, and order sentences. I will actually go through each of those with examples, and we wanted to make sure that we measured the different processes and what those processes would be, as well as measuring the outcomes. And we were looking for positive outcomes. So a lot of the governance committees managed a lot of these decisions and the different outcome measures that we were going to target. Here's a list of some of the target medications. This is actually a pretty long list. This is just the first of the 2 lists that we created. So you'll see the usual suspects, commonly used medications in the elderly, but they should be used with caution. There's another list that's continued. Again, some other medications. I'm not going to go through each of them in detail here. So more details on what our IT interventions were. I mentioned we created alerts, and these alerts were notifications to our clinicians to use caution. We provided alternative medications within those alerts, as well as the ability for the physician to order pharmacist consults. We also updated our order set content to add comments on the potentially inappropriate medications for the elderly. We also created what we call smart orders, and I'll describe that in one of the subsequent slides. We actually had some specific inclusion criteria for our alerts. Number one, it was only firing for the CPOE and not for the pharmacy application. We decided that it would be any patient age greater than 65 years of age. We had specific inclusion criteria for the encounter types, so we only targeted emergency room, day surgery, inpatient observation. We also made sure that the alternate therapies were included in the alerts to the extent that was possible. And then we also created different alerts for providers versus non-providers because we wanted to make sure that the non-providers were within the scope of practice. We also had some exclusion criteria. So we excluded inpatient hospice. We excluded meperidine from firing if the patient was in the PACU. We also excluded patients with active mechanical ventilation and if they were ordered lorazepam, as well as exclusion of two order sets, specifically the adult status epilepticus and the seizure observation order sets. And these were all based on looking at data right after go live or before go live when our alerts were in testing mode, and we presented that data with our key clinical stakeholders, and they were the ones who pointed this out and ensured that we made these changes before we went live. So here's a screenshot of version 1 of our alert. In this screenshot, you'll see that this alert provides the information, shows the alternatives, and allows the clinician to either cancel the order that they're placing and that is defaulted, or the ability to override the alert and continue with the order. Then as we got working with our stakeholders, we made more changes to our alerts, and this is version 2. You'll see the same alert has been built but with alternatives, and depending on the clinical condition, we've provided different alternatives and the ability for the clinician to order the alternative within the alert. But by the time we got to version 3, we also added the ability for the clinician to order a pharmacist consult. And the pharmacist consult actually included details of what the consultation was for. And in this scenario, you'll see it was for Beer's criteria for the short and intermediate benzodiazepines, short and intermediate acting benzodiazepines. This is what the order for the clinical pharmacist consult looks like. It contains the details, the reason, and the medication that is being consulted on, and that becomes a task for our pharmacists who track these tasks and complete them. So they will make the contact with the physician and provide the consult. I talked about having a different alert for the non-providers. So this is an example of a non-provider alert. You'll see that it asks the non-provider to contact the provider and discuss the alternative therapy. The ability to order alternative therapies is not within the alert, and the cancel is defaulted. I mentioned the smart orders. So smart orders are embedded within the order sets. And the way that we built it is we added, number 1, comments within the order set. So in this example, you'll see it says ketorolac will be hidden in patients greater than or equal to 65 years as part of Beer's alert rules. And in this example, the patient is 59 years old, and you'll see that the ketorolac is available. But when you go to a patient that is 81 years old, you'll see that ketorolac is not available to them. And the comment on top helps the clinician understand that ketorolac is hidden. Now, the clinician does have the ability to go outside of the order set and place the order for ketorolac, but when they do that, they will get the alert. So we just want to make sure that we're making the right thing, the easy thing to do. And if the clinician decides that they still need to order the medication, they will get the alert and they will have to address the alert. So as we started to measure some of the work that we accomplished with our Beers List alerts, the first thing that we wanted to look at were the functional measures and truly understand whether our alerts were working. Do we have an understanding of how often they're firing, and are we at a risk of over-alerting? And whether our order sets and order sentences are working as they should be. So to help with that, we have a daily alert trend included in one of our alerts dashboard. You'll see here in the screenshot that they're the periodic dips. Those are pertaining to the weekends. So we don't see any significant spikes or reductions, which may indicate that there's something wrong with the alert or it's not working as it should be. And at which point of time we can go in and start doing some further investigation. Then looking at process measures and getting an understanding of how our clinicians are responding to our alerts and the notifications, and how our clinicians are using the order sets and order sentences. To do that, here's an example of the dashboard for our Beers criteria alerts. It tells us exactly when the alert was created, the number of alerts. This is data, I believe, for a month. And you'll see the override percentage. Yes, the override percentage is significantly high. It's close to 90%. But that allows us the opportunity to go in and drill down further on the data and look at problem areas. That override percentage was a little bit higher. We've made significant changes to it to bring it down to 89%. We also have the alerts for 1,000 orders. That is meant to help us understand how often these alerts are firing for these orders. If that number was a little bit more higher, closer to 800 or 900, then we know that we may be at risk for over-alerting, so it requires us to look at the alert logic and identify opportunities for optimization. Coming to outcome measures, we want to look at our good catches. A good catch occurs when an alert fires to the user and it is backed out and the therapy is changed. So in our example of Beers criteria alert, the physician sees the alert and decides not to order the Beers criteria med for the elderly patient. And one of the things that we also wanted to look at was, what are the volume of orders for Beers criteria meds for elderly patients? Have we started to see a decreasing trend in those orders? But before we did that, we also needed to look at whether we were seeing more elderly patients in our system, and we needed to account for that. And to account for that, what we did was we normalized the data to look at number of orders for 1,000 elderly patients aged greater than 65 years. And then finally, one of the other outcome measures is to look at our serious safety events. Are we having a reduction in the elderly patient falls? And these have to be specifically related to medications. So we looked at that as well. And what our data shows us was that from a good catch perspective, in this screenshot here, you'll see there's about 59 good catches for a month, and I think this is for just one specific Beers criteria alert. But when we look at the entire gamut of the Beers criteria alerts that we've implemented since 2015, we've had a total of 33,070 good catches since those alerts have been implemented. And then I talked about the number of orders. So this one is an example of lorazepam. So the number of orders for 1,000 patients since the alert go live, we've had an 18% reduction. Same data for alprazolam, we've had a 50% reduction in the number of orders for 1,000 patients. And for ketorolac, since our alert go live, we've had a 36% reduction. Now, this data here, what it shows is for the top 7 drugs, which accounted for 80% of all of our orders. And what you'll see is that we had an overall 28% reduction since the implementation of these alerts. And when we start to look at the financial impact for the potentially inappropriate medications in the elderly patients, we use some of the literature from back in 1997 by Dr. Bates and his group that talked about the relationship between potential adverse drug events that are prevented and their correlation to actual adverse drug events and estimated lives saved and estimated serious safety events prevented. And so even if we went with the most conservative number and say that for every 1 in 32 potential medical errors that were prevented, if they would have become an ADE, we're still looking at avoidance of 1,033 adverse drug events. And when you look at the costs associated with adverse drug events, and those numbers do not account for inflation, the 2,595, even with that number, we're looking at close to $2.7 million in cost avoidance as a result of those AD preventions. And then we're looking at approximately 10 lives saved and 124 SSEs prevented, or serious safety events prevented. So that helps us get an understanding of the positive impact to our patient population. One of the other things that we also noticed was that there was a significant reduction in the number of elderly patient falls related to the Beers List meds. And so all positive outcomes from this work, and we're very, very proud of this work that we've done to improve the patient safety for our elderly patients. And that actually brings me to the end of my case study, and I want to thank you for your attention.
Well, thank you, Suraj, for joining us today and presenting on your and want to remind folks where to go find this case study and other information on how to apply for Davies awards. That information can be found at the HIMSS Davies website at hims.org/Davies. You can find this use case and other use cases on Great Davies outcomes at this website. So again, thank you, and hope you have a good day.